Thermo Fisher Scientific presents The Next Step, a diagnostic testing series. Created to help physicians appreciate the nuances of laboratory testing with experts, focusing on demystifying laboratory testing in common but sometimes difficult to diagnose diseases, such as rheumatoid arthritis, systemic lupus erythematosus, and celiac disease. This video focuses on rheumatoid arthritis and the key clinical areas of testing. Your host is Dr. Anug Vora, the U.S. Medical Director Autoimmunity at Thermo Fisher Scientific. Dr. Vora, in his current role, directs institutional and physician education. He has lectured extensively at medical schools in the U.S. and Europe, including Harvard, Stanford, and the Karolinska Institute on the application and appropriate utilization of laboratory testing.
I'm Anug Vora, and as a laboratory physician and clinical pathologist, I understand the difficulty that many of us face in navigating the complexity of laboratory testing, especially with newer technologies such as next-generation sequencing or the latest clinical biomarkers. But even older tests can be confusing if not ordered in the right sequence or used with the correct clinical scenario. In this series, we'll address 4 key questions when it comes to laboratory testing. Who should be tested? When should these tests be utilized? Which tests are appropriate for a diagnostic workup? And finally, and most importantly, what should one do with the results? Numerous paradigms exist in diagnostic testing. However, 3 key concepts should be considered when utilizing laboratory tests. First, for most diseases, such as rheumatoid arthritis or SLE, a single laboratory test is not diagnostic, but rather the diagnosis is made by a combination of clinical signs and symptoms, with laboratory testing confirming the clinical symptomology. Second, no test is perfect. That is 100% sensitive and 100% specific. And all tests will either falsely label patients as positive when they don't have disease and miss patients when they do. The goal is to minimize this problem by testing the correct population. That is to test those that are at risk, thereby increasing pre-test probability and improving the effectiveness of testing. Third, it is essential that you are familiar with the platform and methodology utilized for the test ordered. The corresponding results are not always comparable since the performance varies between manufacturers. When in doubt, it's always a good habit to ask the clinical pathologist at your institution for guidance. He or she will be able to walk you through the advantages and disadvantages of different laboratory testing paradigms.
Laboratory testing in rheumatoid arthritis. Rheumatoid arthritis, or RA, is a systemic autoimmune disease characterized by chronic joint inflammation that ultimately leads to irreversible joint destruction. RA affects approximately 1% of the world's population.
Please recall that a diagnosis of rheumatoid arthritis is established by a combination of clinical criteria, imaging, and serologic findings. In this video, we'll discuss the next steps in the laboratory testing of rheumatoid arthritis.
Who should be tested?
Any patient with symmetric polyarthritis, morning stiffness, or a family history of rheumatic disease should be considered a candidate for an RA workup, especially if their arthritic symptoms have been present for more than 6 weeks.
When should testing be performed?
It is important to understand that early testing for RA is crucial, since numerous studies have now demonstrated that early identification and consequently appropriate treatment of at-risk patients prevents irreversible joint damage and the loss of function seen in chronic RA.
Which tests are appropriate for a diagnostic workup in rheumatoid arthritis?
In contrast to other conditions such as diabetes, where a single test can label a patient pre-diabetic or diabetic, in RA, as well as other complex autoimmunity diseases, laboratory testing is utilized to triage patients, determining the need for additional or ancillary testing. Consequently, most patients will require a battery of tests, though often these can be ordered simultaneously. Let's discuss these now.
What are the laboratory tests that should be used in testing for rheumatoid arthritis?
Multiple authorities, including the American College of Rheumatology, recommend the following diagnostic tests. Rheumatoid factor, which is an antibody against the Fc portion of human IgG, can be detected in the majority of patients with RA and has historically been used as the key diagnostic marker for RA. However, because of its low specificity, it has limited clinical utility, especially tested in isolation, since it is also positive in numerous other diseases, as well as healthy controls. Many specialty physicians utilize the individual RF isotypes, IgM, IgG, or IgA, in disease prognostication. Only RF IgM is included as a diagnostic criterion by the American College of Rheumatology. Antibodies to citrullinated peptides, for instance CCP, are highly specific biomarkers for the diagnosis of rheumatoid arthritis, with a specificity of up to 98%. Several proprietary versions of CCP antigens exist and are labeled CCP2, CCP3, CCP 3.1, etc. However, note that despite the sequential numbering of these antigens, higher numbers do not signify improved clinical performance. All antigens exhibit various sensitivities and specificities, with CCP2 actually demonstrating the greatest combination of sensitivity and specificity for RA. Keep in mind that both RF and ACPA markers should be measured in tandem, since many times one marker may be positive while the other is negative, or vice versa, especially in early stages of disease. Combined testing improves the sensitivity and specificity of establishing a diagnosis of RA. Elevations in acute phase reactants, such as ESR and CRP, are consistent with an inflammatory state and used as a diagnostic criteria for the diagnosis and monitoring of rheumatoid arthritis. Studies so far have not demonstrated superiority of one reactant versus the other, or their combined use for this purpose. Antinuclear antibody should be performed to exclude other rheumatic diseases, since early RA may be difficult to distinguish from other rheumatic diseases, including the arthritis of systemic lupus erythematosus, or SLE. A complete blood count may simply show persistent anemia and thrombocytosis, consistent with inflammation, and may be the first clue as to the etiology.
Let's recap some of the important tests for the workup of rheumatoid arthritis. Rheumatoid factor, anti-citrullinated peptide antibodies, anti-nuclear antibody, complete blood count. Additional ancillary tests to consider.
MBDA, or Multiple Biomarker Disease Activity Test Scores, are panel tests that combine multiple markers linked to a proprietary algorithm to predict the disease activity, though these are not utilized for the initial diagnosis of rheumatoid arthritis. Proponents of panel testing state theoretical advantages with this methodology compared with conventional tests. However, the role of these panels in routine clinical practice still remains to be established. It is vital to understand the role of serology in this clinical scenario is to assist in confirming the clinical diagnosis. No single test should be used in isolation to make a diagnosis or treatment plan. However, if the diagnosis of RA can be confidently made, there should be no delay in referring the patient appropriately or commencing patients on definitive therapy, since early and rapid control of inflammation with DMARDs prevents irreversible joint destruction and loss of function.
Thank you for watching The Next Step, a diagnostic testing series. For more information or to watch additional videos, please visit our website at thermoscientific.com/Fadia.